Okay, hello everyone, I'm Faria and I'm one of the F1s at Charing Cross Hospital, and we've got a case presentation for you today. So Mrs. X is a 52-year-old female Somali woman who presented with nausea and vomiting. This is on a background of sore throat, dry cough and intermittent fevers, which her son also had at home. They all had negative COVID tests and she's had her first COVID vaccination. Alongside the nausea and vomiting, she's also had associated left upper quadrant pain, feeling generally unwell, fatigued, and just not her usual self. She denies food poisoning. She cooks all her food at home herself, and no one in her household has nausea or vomiting either. In terms of a systems review, apart from a reduced urine output, there were no other issues. She has a past medical history of hypothyroidism, epilepsy, diabetes, which we think is gestational following her first pregnancy, H. pylori. She was treated for latent TB in the past, and she's also had a previous Shigella E. coli colitis requiring ICU admission. In terms of her medications, she's on atorvastatin, insulin, levothyroxine, and Ramapro. And so on admission, generally on examination, she was fine, apart from mild epigastric tenderness and a temperature of 37.9 degrees. Investigations-wise, her white blood cells were 5.6, her CRP was elevated to 81, and she had a hyponatraemia of 112, which responded to a liter of IV fluids to 116. She also had low electrolytes as well.
Okay, so look, do you want to just go back a bit and let's ask the audience what they think. So just go to your first slide with the history on it. Okay, so nausea and vomiting, everybody. So anybody going to tell me what they think might be a cause of that? I think there's some students on. Can I get a student to helpfully? Oh, thank you, Mel. Indeed, really key. And Killian has raised his hand. Killian, do you want to unmute and tell us what you think? No, Mel, it's fine. Don't apologize. Thank you. That's what I need. I need people to say things like that. So that's really, so viral gastroenteritis, excellent. Any other thoughts from students? Killian, you put your hand up.
I don't know if you can hear me.
We can.
Brilliant. Pregnancy.
Okay, very good. She's 52, okay, but it's an important thought, so thank you. Any others?
Hi, would a pancreatitis be possible?
Yeah, it's certainly a possibility, although usually there's a lot of pain with pancreatitis. Okay, and then do you want to go to the next slide? Okay, so there's quite a lot of past medical history there. Notice the latent tuberculosis. She hasn't in the past had pancreatitis, you heard. Someone's asking about the spleen. What is it when you say spleen question mark? What do you mean? What's the question? Do you want to unmute and just tell us what you're asking us? QQ.
Sorry, I was thinking, I don't know, inflammation of the spleen, or something.
Okay, that's a very unusual diagnosis, splenic inflammation, but we'll just put that to one side. I don't think that's a likely cause. Okay, and you see the drug she's on. She's on a bit of insulin, Levemir long-acting, Novorapid 3 times daily, and she's on some blood pressure control. Okay, and then next slide. And you've heard the examination and the results. It's like fever there, notice. Okay.
Okay, so her blood-borne viruses were also negative. Chest X-ray didn't show any consolidation. Urine MCNS was also negative, and she had a CT abdomen, which also didn't show a cause of her symptoms. Given her temperature spikes, blood cultures were taken, which were initially positive, and so on the recommendations of micro and echo was performed, which didn't show any abnormalities. Later on, ID and micro continued to review, check sensitivities, and they found that to be a contaminant, so that wasn't looked into further.
Okay, just hold it there. Go back there. So we have ID. So any thoughts about what that was? She has a positive blood culture. What do you think was on the blood culture? Somebody.
Could it be like a Staph aureus? That's why an echo was performed.
Yeah, very good. It could be staph. Of course, it probably ended up. So they can't tell at the start. So they say it looks like Staph aureus, really dangerous, but it will turn out to be Staph epidermidis. And that's why they then said it's contaminant. But they only know that after they culture it for a couple of days. So just in case it's Staph aureus, they say give antibiotics. And then when they get the results back, they say, oh, actually, it's not Staph aureus. And so we can exclude that as a diagnosis. Does that make sense? Okay. Thank you. Do you want to carry on, Priya?
Yeah. So as I think one of the participants mentioned, they were querying viral or bacterial gastroenteritis, especially given her previous background of the Shigella E. coli colitis. She was treated with IV fluids, and since the sodium was responding, they thought it was hypovolemic hyponatraemia. And as I said before, she was reviewed by ID, and they suggested putting her on amoxicillin for a presumed CAP, a community-acquired pneumonia. And there were also pending respiratory viral screens and acid-fast bacilli given her background of being treated for TB. And so this patient was handed over to the evening SHO for a review of her sodium and whether she needed further IV fluids. And this SHO got a call from biochemistry to let them know that her cortisol was 58. So the SHO reviewed the notes and he found that the history was consistent with an adrenal crisis given the nausea and vomiting, the lethargy, abdominal pain, and her biochemical markers. It was also noted that her blood glucose was 5.4 and she hadn't required any of her insulin since admission. And so the impression was a new adrenal crisis triggered by an acute infection. And the working theory was that it might have been secondary to her previous TB. So this was discussed with the consultant on call, who advised stopping the IV fluids and giving her hydrocortisone and adding on some of the other pituitary bloods, including LH, FSH, etc., with an endocrinology review pending for the morning.
Okay, any questions from the audience? Or you're all happy with that?
Her blood sugars level not requiring insulin. Is that related to the adrenal crisis, or is it just something that happened?
Well, it's not something that happened. That's a really good question. Yeah, because if you have someone who likely to be type 2 diabetes and need insulin because they had poor control and suddenly the control's better. So, and that low cortisol there, 58, because normally a 9M cortisol should be above about 150, 200, or even 600. So that is so maybe a lack of, so cortisol is a glucocorticoid, and if you're lacking it, then your sugars fall. And in a non-diabetes patient, sometimes you have hypoglycemia as a presentation of a low cortisol. So it sort of fits, but it's not quite perfect. Okay, any other questions from anybody or thoughts?
Why stop the IV fluids?
It's a good question. Well, maybe they were thinking of SIDH. Maybe, I don't know. I didn't see. I don't know actually. So I think maybe it was overhydrated, because normally for N and V, and we'd give more saline.
I only asked because I'm pretty sure I'm the consultant in question here. I can't remember saying stop IV fluids, but correct me if I'm wrong, Faria.
Yeah, the documentation said stop IV fluids. So I don't know where that came from.
Okay, maybe it's something I said as misinterpreted. I apologize. I don't know why that happened. Cool.
Okay, fine. So do you want to carry on then?
Yeah. So her bloods were back. Her TSH was 1.19, 324 was 6, cortisol, as we said, was 58. LH and FSH were low, and her prolaxin was 46. So with this information, any ideas about what's going on?
Let's start with the students and work upwards. Any student, tell us what you think that is. Come on, be brave. Okay, unmute, put your hand up. Who volunteered last time?
Is this low cortisol level?
It is a low, sorry, yes, it is a low cortisol for 9 a.m. So there isn't a normal range because it depends on what time of day, but for 9 a.m., it's a low cortisol. So what else do you notice about this?
She also has a very low free T4 levels as well.
Yeah, she's got a low free T4, and you'll see the TSH is sort of in the normal range. Now, if your free T4 is that low, then you should have a high TSH. So the TSH is not responding. And then she's 52. And so if she were menopausal, and I don't know if she is, then she should have high LH and high FSH, like over 100. And then the prolactin's low as well. So what does that, put all that together? Not responding TSH, low cortisol, low LH, low FSH, and low prolactin.
Hypopituitaryism?
It looks like that, doesn't it? Yeah, so the pituitary, so well done, that's what it is. Okay, thank you, hypopituitarism. Okay, and that would also fit, so it's not quite an Addisonian crisis, it's just pituitary failure. Okay, Farid, do you want to carry on?
Yeah, so at this point, I went with the endocrinology registrar to review her on her ward, and further questions were asked given her blood results. And it looks like she was previously investigated for cervical lymphadenopathy, and that's why they investigated for TB and found that she was MAN2 positive and treated her for 6 months. She's had intermittent headaches for many years. And as we said before, she wasn't requiring her insulin while she was in hospital. More interestingly, she says she had menopause at age 40 in 2009, and this was following a stillbirth at 42 weeks, where she had a postpartum hemorrhage requiring 8 units of blood transfusion. She was septic and was on ITU for 13 days after, and she's not had a menstrual period since then. Sorry.
Any thoughts from the audience about this page?
Sam, how relevant is the birth 11 years ago, whether hypopituitarism can last that long?
Yes, it's a really good point, and it certainly can. She had so she became menopausal at the age of 40, which is a bit young, or so she thought, following a stillbirth, right? And she almost died by the look of it. And needs lots of blood, but has survived.
Is this Sheehan syndrome?
It certainly is something to think worth thinking about, yeah, because it's certainly a possibility. It fits perfectly with the timing, because she had a postpartum hemorrhage, and then she labelled herself as menopausal. But of course, if you're menopausal, you have a high LH and a high FSH, so it's certainly possible that she's got that. Yes. Okay, do you want to carry on, Priya?
Yeah. So just a summary of her bloods there again. And once the endocrinology registrar saw her, obviously we mentioned that she's got secondary hypothyroidism, hypoadrenalism, and amenorrhea, which does suggest the pituitary pathology, Sheehan syndrome being most likely. And the fact that her prolactin was low suggests that it was less likely to be complete pituitary failure. And the plan thereafter was to do an SST, baseline ACTH, an MRI of her pituitary gland, and to start her on prednisolone and increase her levothyroxine with endocrinology follow-up in the community as well. So I think Prof. Miriam's going to take over.
Okay. Got any questions? And then we'll talk about it. Any thoughts? Someone asked a question, I think.
Could I just double check what for the short synapsin test for the ACTH? That's just to confirm that the adrenal glands are healthy.
Yes, they won't be healthy. It's actually to confirm that they're not healthy, because if she has got partial, because she's still okay without any, she's been okay for, as you say, many years, and that's because her cortisol is not zero. She's got a little bit of functioning pituitary, and it's just enough to keep her going with a cortisol that isn't responding to stress. And now whatever it is caused her to come in with vomiting, and she's become unwell, and she's decompensated, but she has enough cortisol to get by on a good day. And she may have many other problems, of course. So we do a synapsin test to see if you've got adrenal atrophy caused by pituitary failure, then the cortisol will respond only weakly. And so we have various reference ranges to decide if it's pituitary failure. This is not to diagnose primary adrenal failure, because that would have a cortisol of 0 and that won't respond at all. But in this case, because we think it's pituitary, we have different reference ranges. Any other questions? And I'm just going to go through. I'm going to ask you to advance a slide, if that's all right for you, and I'll just talk to them. Is that all right?
Mm-hmm.
Okay, do you want to go on to the next slide? So this slide shows the dangers of becoming pregnant in Sweden in the year 1800, in the UK 1847 when the record started, in Sri Lanka in 1900, and look at that risk of death. This is mothers I'm talking about, okay? So if there's 1,000 deaths per 100,000 live births, so that's like 1 death in 100. So what that means is, if you become pregnant, if 100 women become pregnant, 1 of them will die in either in childbirth or before delivery. So very risky thing to become pregnant before 1940. Look at the next slide. So this is England, okay, showing the dangers of becoming pregnant. So 50 deaths per 1,000, okay, until 1940. And then, next slide, magic happens, okay? Why so many deaths and why the improvement, okay? And essentially what's happened. Anyone want to reply answer that question? 1940, magic year.
Penicillin. Puerperal sepsis.
Yeah, puerperal sepsis. So antibiotics appeared. So penicillin got rid of strep, beta hemolytic strep that caused lots of mothers to die of puerperal sepsis. Half of the deaths were due to that. The other half were due to postpartum hemorrhage. And the fall is due to amazingly good obstetric care in some countries, but not others. This is England. Okay, so England have the risk now of a pregnancy is in the 1 per million sort of level. 6 per million is very, very low now. But it used to be a very risky thing to do. Okay, next slide. So now I'll talk about portal circulation. Now, portal circulation is a circulation with capillaries at both ends. Okay, so if you follow any vein or any go back one. If you follow any vein or any artery, one end always ends in the heart. Okay, except in 2 places: the hepatic portal vein, which goes from gut to liver, not the heart, and the pituitary. And the pituitary basically gets its blood supply from the hypothalamus. And now go to the next slide. Okay, so this shows the reason we have this capillaries is that you've got to carry the releasing hormones from your hypothalamus into the pituitary that tells the cells what to do. So for example, CRH will stimulate the release of ACTH, which will stimulate the adrenal to make some cortisol. Okay, and so on. So all of that is controlled, and you need those capillaries at both ends. Next slide. So what that means is if your pituitary grows, it becomes critically ischemic because there isn't a good arterial supply of the pituitary gland. So normally, at the end of pregnancy, your pituitary is about 3 times bigger than normal because it has lots of lactotrophs to enable you to breastfeed, to make prolactin. And so you have a very big but ischemic, just about bit ischemic, but there's enough blood coming through those capillaries, but there's no mechanism to increase it if there's a sudden change because it's only got one little artery there. Okay, next slide. Okay, and this will show the same thing again. Okay, so the anterior and posterior circulations, the anterior goes through that primary capillary plexus. Okay, next slide. Okay, so
I mean,
yes, question. Was that a question, somebody? Okay, so now normally, if you have a tumor anywhere in the body, the tumor cells release angiogenetic factors that increase the blood supply of that tumor, and so it can grow and grow and grow. Sometimes it outgrows the blood supply. There are some new drugs that work by preventing that blood supply growing that causes tumor infarction, but the pituitary cannot do that. So just go advance one. Yeah, not the pituitary gland, okay, because the pituitary has those capillaries. So if it grows, it will be a bit ischemic. Okay, next slide. So in normal pregnancy, the pituitary grows. Next. Okay, and that's because your lactotrophs hyperplays. And your prolactin goes up to about 40,000 from a normal about 300. Okay, and that's how you make milk. Okay, next slide. So then, as happened to this patient, and this is from a very old textbook of what happens in Sheehan's, and it's still correct today. You have a postpartum hemorrhage, your blood pressure falls. Now the pituitary gland has been growing, growing, and growing, and it's a little bit ischemic, and then you suddenly drop your blood pressure. Not that much, but enough to infarct your pituitary, but not enough to cause renal failure or anything else, although she was in coma, this patient. But then what happens is they fail to breastfeed. And if you ask her, she'll tell you, yes, I couldn't breastfeed the last child. And then they become deficient in ACTH, but not aldosterone. And that's why they don't have a proper adrenal crisis. Because if you have Addison's disease, then you're in real trouble because you lose two hormones, cortisol and aldosterone. So you then cannot survive without steroids. But this patient has a normal renin aldosterone axis, so blood pressure is maintained. She just is missing the glucocorticoid cortisol, and there is a bit. You need cortisol when you're under stress, though, in larger amounts. And then, as you saw in her, she's LH and FSH deficient. Hence, she thought it was menopause, but no, it's just lack of gonadotrophins. And then she's TSH deficient, she's therefore hypothyroid. Now, the TSH is normal to measure, but it should be much higher. Okay, and then I don't know if she's pale. She's got black skin, but maybe she's lost a bit of color. So that's a question that's worth asking. Okay, can I ask you any questions about this so far before I tell you about a little bit more about it? Or is it all clear? No? Okay, next slide. So here's the other question, right? So she presents up with a low sodium, okay? And if you want to advance the next slide, because that's a question that people ask, okay? Because she's got aldosterone, so that should maintain her sodium. And the reason, we discussed it in the past, is these aquaporin channels depend on steroids. So just go to the next slide. There's three aquaporins. Aquaporin 2 is the one that matters. Aquaporin 2 is the one that responds to ADH and makes you resorb water, okay? So if you just play this cartoon one by one, so what happens is ADH will bind to the V2 receptor, okay, and that will then make aquaporin 2 move into the renal tubule, which will then enable water to be resorbed, okay, and therefore you concentrate up the urine appropriately, okay, and then as time goes on, you either throw away or recycle the aquaporin 2 receptors. Now that bit, as it says, that is steroid dependent. You need cortisol or prednisolone to pull that aquaporin back in. And if you don't have any steroid, then you're in trouble. Okay, keep going. So not enough steroid, and that recycling doesn't happen, which means that she will keep on resorbing. Now she has got some cortisol, so she's just can't cope, but now she's under stress. Keep going. What's happening now is her water's being resorbed even in the absence of ADH, okay? Because there's no mechanism to switch off the effects because of lack of steroid, okay? And so not enough steroid, there's no notice ADH bind to the V2 receptor and the water's being resorbed. So she will have what looks like SIDH, but really it's lack of steroid. Okay, just advance one, I think. Yeah, okay. And so this is the data I've got this from a paper that shows how you need steroids to retrieve aquaporin 2 into the vesicles. Okay, next slide. Okay, and now we use prednisolone. And when you give people once daily prednisolone, you replace that missing cortisol, and that will basically enable you to pee out that free water and normalize your sodium. Next slide. Okay, do you want to summarize then?
So in summary, we've got a 52-year-old lady with stress-induced hyponatraemia, and it turns out that her respiratory screen came back positive for enterovirus, rhinovirus, and parainfluenza virus. And as we mentioned before, she's got pituitary pathology, likely Sheehan's syndrome, and we've mentioned the follow-up that she will be having upon discharge from hospital as well, which includes the MRI scan, the prednisolone 4 milligrams, and increasing her levothyroxine dose.
Okay, thank you very much. Any questions? So she's going to now go back, yes, just stay on this slide really. So she's going to be, as long as she takes a small dose of prednisolone and enough thyroxine, she'll be normal. She's going to be completely fine. And she's 52 now, maybe some HRT, but that's not essential. What she really needs is a small amount of prednisolone and some thyroxine, a bit more thyroxine. Okay, thank you for that. It was a really good case, really well presented, and I hope you all enjoyed that. Any questions?
You may have mentioned this, but would you be surprised that she's been absolutely fine for 10 years and it was a relatively minor gastroenteritis that kind of precipitated this crisis?
Yeah, she probably hasn't been fine, you know, she probably has been grumbling quite unwell on and off. Any stress would have made her feel unwell. And in fact, I mean, she's fine and with a bit of fluid and so say normalized, and she's discharged herself, so she's actually quite well. She's got enough cortisol to get by. This is not the first time I've seen this exactly the same story. Some years ago, we had a patient who presented with hypoglycemia after surgery. So the patient had been well for 10 years, but had a cholecystectomy and then presented with hypoglycemia. Yes, good question, George. She does need a higher dose of pred while unwell, although she's not unwell now. She has actually self-discharged because she's got children to look after and things. So yeah, she probably needs a bit more. Actually, I'm not sure she needs a bit more, you know. She might need a bit of, just need a replacement to start with. The rules are, everybody, that you double your dose of steroid for 3 days around this kind of infection. So if she was on pred, she wouldn't have been ill at all. But if she were to get on 4 of pred, nausea and vomiting and diarrhea, then we would double the pred to 8 milligrams for 3 days and then go back to normal. And into thyroxine replacement, I mean, she's now on, all you need is 2 or 3 days of pred, and then you can start the thyroxine as well. Yeah, you must give the steroid first. One of the problems, certainly if you use hydrocortisone on a ward, if you prescribe both, you end up getting thyroxine first because thyroxine's on all the wards and hydrocortisone isn't, but prednisolone always is, so it's fine. But it is important to, as George has pointed out, some really important teaching points, okay? Give the steroid before, because if you give thyroxine alone, you increase the metabolic rate of the patient, increasing the work that needs to be done, and therefore increasing the need for the steroid. So in fact, the hypothyroidism may be one of the reasons why she's protected herself from needing so much steroid, because she needs less because her basal metabolic rate is lower. So all these things are compensated. But if she takes pred 4 and thyroxine a bit more, she'll have a much happier, healthier, and longer life. Okay, thank you all very much. Any other questions or thoughts? So an important lesson, Sheehan syndrome, it's in the UK, very, very rare because we've got such good obstetric care. But in other parts of the world, it remains very common. And I mean, childbirth remains a very dangerous thing to do in many parts of the world. And yes, really beautifully presented, thank you. And I've recorded it so we can save that.
Thank you.